it could be something happening in here, some kind of conduction issue. Maybe fluid got into the ear and now you have some kind of blockage, for your ear inserts. Something's happening before here. So increased latencies from waves 3 and 5 with a normal wave 1 is an eighth nerve injury. So they're working over here, they damage the nerve here. This is still working. Distal nerve is still working. You're still getting wave 1. Wave 3 and 5 shift out. Increase in wave 5 only. This could be changes, functional changes occurring higher in the auditory pathway. Could be perfusion related, and it could also be retraction, stretching of the nerve. I've seen where wave 5, where they've retracted the cerebellum, and the only thing that kind of started shifting out was wave 5. And that's just because they're probably causing pressure on the brainstem itself at that point. So latency changes have been favored over amplitude changes as indicators of injury to the auditory nerve. The ABR peaks are less variable than the amplitudes of the latencies are less variable than the amplitudes. So this is showing you a shift of wave 5 starts going way out. That was caused by compression of the brainstem and retracting the cerebellum. As soon as they basically took off the retractor, it came back to normal. And also, if you notice, we've also lost it on the contralateral side. Again, brainstem. You could lose both your wave 5s, with a brainstem compression. So, as you can see here, shifts out. They took the retractor out. Again, you have to correlate it to a change. We knew they had the retractors in. Everything was fine. It was going perfectly. And then this wave 5 started to shift way out. And we said, hey, do you have your retractors in? Sometimes you can't see what they're doing. And they go, yeah. We tell them, and they took the retractors out, and everything came back to normal. So just be aware of that. Transient latency increase could be due to drilling, irrigation, retraction, surgical irritation, hypotension, positioning. All these things can affect your latency. So you have to be aware if it's transient, it's going back and forth. They could just be there working. And bears are funny that way. They're not. You would think for modality it's not affected by anesthesia. It's affected by everything else, and they move around a lot in surgery. So. When you see something like this, it's very specific. It's one wave and it's going out. That's cause for alarm. But if they're all kind of going throughout the surgery, it just could be to, like I said, temperature or drilling. But you want to correlate it. If they're just exposing, you start seeing changes, then you know it's not them. And I think I showed you guys a case where we had that where the entire bear shifted out. They hadn't done anything. We knew it was temperature. It had to be temperature. And the patient woke up fine. Persistent latency increase is retraction or pressure on the auditory nerve, cerebellum, or the brainstem. Transient loss of the bear could be retraction or pressure or surgical maneuvers. Ipsilateral permanent loss of the bear, surgical interruption of the auditory nerve. So if they go through it, you lose your bear. Now, sometimes they want to go through it. So, but usually if they're going through it, it's because they already have a hearing loss. You're probably not going to get a bear in that side anyway. But sometimes they do go through it on purpose, and I'm going to go into that in a minute. Contralateral BAP loss, so you're doing bilateral bears. This could be swelling of the cerebellum. So cerebellar edema could cause, just from manipulation, could cause just pressure on the brainstem, and you lose that contralateral. So if we look at this, this was retraction on the cerebellum with pressure on the brainstem, and not only did we have a shift out on the ipsilateral side, but the contralateral side shows a complete loss of wave 5. So what are the surgical risks to losing your bears or having a change in your bears? Avulsion, so just tearing the nerve away. Compression, cutting, stretching. Ischemic risks include occlusion on the cochlear artery, the anterior inferior cerebellar artery or the basilar artery, dissection of the anterior inferior cerebellar artery or the vertebrobasilar artery, or a vasospasm of the cochlear artery or the anterior inferior cerebellar artery. And then you can have a thermal injury, heat caused by cautery or the drill. So now let's look at why we do bears, why we do cranial nerve 7, and why we do cranial nerve 5 in surgery. First, we'll talk about microvascular decompression for trigeminal neuralgia. This is done via a posterior fossa approach. 3-inch curve, skin incisions made behind the ear. Skin and muscles are lifted off the bone, folded back. Then they make a 1-inch opening into the occipital bone with a drill. The bone's removed to expose the protective covering, the dura of the brain. And then the dura is opened with surgical scissors and folded back to expose the brain. For all, craniotomies, this is basically the steps. Skin, bone, dura, open, and then finding the, tumor or, vessels or nerves that are at risk. In this case, these are actually probably the easiest in the sense that there's no easiest for surgeons in the sense there's no tumor involved, in terms of brain surgery. So it's a microvascular decompression. So they're looking to find the vessel that's impinging the trigeminal nerve. So basically, retractors are placed in the brain. They open a corridor to the trigeminal nerve at its origin in the brainstem. So it's highlighted here. So we're talking about right here. Surgeon exposes trigeminal nerve and identifies any offending vessels causing the compression. The vessels and the nerve are often restricted by connective tissue that has to be dissected. So they're connected by this kind of connective tissue, and it has to be avulsed. And usually the offending vessel is a superior cerebellar artery, which is showing you right here. This becomes, it's highlighted. It basically impinges the fifth nerve, and they have this. It's called tic douloureux, trigeminal neuralgia. It's excruciating, pain in the face, and they access the nerve here, and they just basically move this off the nerve, and they put a piece of Teflon in there, and they keep the vessel off the nerve with that little piece of Teflon. And then once they place the Teflon or the sponge, they remove all the retractors. The brain they put back into hemostasis, make sure everything's safe. Dura is closed. And then if it's a craniectomy, they'll put a plate on, or they'll put the bone flap back on. It depends on how much swelling there is. What you have to keep in mind for these MVDs or any type of brain surgery is, I don't know when you guys stop monitoring, like in spine surgery. I'd stop monitoring spine surgery as long as nothing's gone wrong when that first suture goes in. And the reason for that is that our anesthesiologists want to wake the patient up, and they're going to turn off the propofol and possibly turn up the gas, and it changes things. In these cases, we wait till the door is closed, because you can still injure something as they're closing, right? You're in the brain. Generally in spine surgery, they're not going to damage anything as they're closing the muscle. So we monitor through closure of the dura.
Yeah. The lead microvases that are, for billing purposes on a spine case, when I was reading something we're talking the closing part, can you still bill all the way through the closing?
You can. You can bill for it.
But the only reason why I'm bringing it up is because I was in a surgery many years ago where a doctor, after he closed, everything he did on the neck case, all the hardware, basically pulled off of where he was working. And then all of a sudden, my EMGs went nuts. And he had to back to reopen, and sure enough, all the screws and everything came loose. So I was just wondering if there should be a different policy that should be put in place, that you've seen it in your history of things.
You know, I think that's a rare experience. I think it can happen. Look, you can, and whatever, you know, I don't obviously dictate your company policy. So whatever, you know, your company wants to do with regards to closing, you know, you can do. Our policy in my group is that as long as nothing's gone wrong with the case, if something's gone wrong, we monitor through closure because we want to see if it comes back. We want, you know, or want to make sure it doesn't change anymore. But if it's been like a straight ACDF and it's completely normal case, or even a better example, a lumbar fusion, that's a little longer than ACDF. Let's say it's a 4-hour lumbar fusion, so they're on propofol for 4 hours, and everything's been completely normal. They put that first stitch in. We want to wake the patient up. We want to, you know, and the only way to do that is for them to turn off the propofol. But they got to keep the patient down for another 40 minutes maybe, right, of closing time. So to do that, they have to put the gas up. And if we were monitoring through that, it would change our waveforms. I'm going to give you a perfect example of this. It would change our waveforms and could lead to a false positive, right? An event that occurs that's not real but looks like pathology. And I mean, it's you know, it depends on how fast your surgeons close. If you're working with residents and you want to capture another hour or two of closing time, you can. You know, that's up to you. Something like that happening is few and far between. Them throwing an embolus it can happen. It can happen every surgery. It doesn't you know, we can only, you know, monitor for so much. You're really monitoring for the surgical procedure, and if it happens post-operatively, you know, if you monitored it, would you have caught it? Yes. Would they have caught that the next day? Would that have hurt the patient right then and there? Probably not. They probably would have caught it later on when they realized, you know, the patient was having excruciating pain. I mean, it was great that you caught it.
I guess that your answer, would really be depending on how difficult the case was, where you made the judgment call.
Right.
Continue.
All right, and that's what we do. So I'll give you a perfect example. Not my group. It was a different group that works at the same hospital, and we were doing a case. And at the end of the case, I went over to anesthesia, and I said, "Hey, we're all done. You know, if you want to change up, and it's part of our it's in our policy and procedure manual. We also let the surgeon know, hey, we're not monitoring anymore, because if they want us to continue to monitor, they'll say, okay, continue to monitor. So we do. So back it up. When I'm done monitoring, I walk up to the drapes. I go, guys, you're okay with me stopping the monitoring so we can wake the patient up? And they say yes, or they say no. If they say no, I continue to monitor. If they say yes, I turn around to anesthesia and I say, hey, I'm all done if you want to start, you know, getting ready to change things up. And usually it's created a nice relationship with anesthesia too, because they turn off the propofol and then we wake the patient up. And literally, we're not waiting around for an hour and a half for the patient to wake up because they've turned the propofol off an hour before, you know? So this was maybe a month ago. I'm doing a surgery. I go walk over to the anesthesiologist. I'm friendly with him. I said, hey, you know, you can change it up. I'm all done monitoring. He goes, oh, okay. He's like, good. He's like, you know, we'll wake the patient up. And he starts telling me a story. He's like, yeah. He's like, you know, a couple of weeks ago, I was in surgery with the other group, and we were doing a brain surgery, and I asked the surgeon if I could. The anesthesiologist said, I asked the surgeon if I can. You know, they were done closing the dura. I asked the surgeon if I could, you know, start, you know, getting the patient ready to wake up. And the surgeon said yes. And he told the monitoring person, I'm turning off the propofol, I'm turning on the gas. They were running a complete TIVA at that point. So he turns on the gas, and all of a sudden the person that was monitoring jumps up and says, we just had a significant change in the SCPs. Stat CT scan immediately. He actually said this in the room. So the anesthesiologist said, I just turned on the gas. And he's like, no, we have to get a CT scan. This is the language used, stat. The patient's intubated, the patient's in pins. They want to roll them down, intubated, based on the neuromonitoring person's call. And the guy's like, well, how about I just turn off the gas? No, we have to get a CT scan. So he turns to the surgeon. He goes, "What do you want to do?" And the surgeon, who's not going to say anything, but says, "Well, we should probably get a CT scan." It was purely guess. So basically, based on just, I don't know what this guy was thinking, because he was communicating supposedly with the anesthesiologist. He made they turn on the gas and it changes waveforms. The point is I'm trying to make is that when you're closing and turn on the gas, it's going to change the waveforms, and then you can end up making a call like this if you're not savvy, I guess, and don't realize what's really going on. But they actually rolled this patient to CT, intubated, and got a CT scan that showed nothing. So not only are you wasting money, time, you're not waking this patient up, you're keeping them under anesthesia longer, and now you're making a real pain for the anesthesiologist, who now has to wheel this patient and get a CT scan while they're intubated. That's a whole nother dynamic.
Yeah, because that's what we thought, where it's just the patient was coming out of anesthesia, and they were starting to wake up a bit, and man, the EMGs went nuts, and then the surgeon's already left the room, PA's closing up, it's almost finished, like the last stitch, and we let them know, we checked anesthesia, and checked everything, but sure enough, they left, and then when she really came out of it, she was in extreme pain, they had to open her back up, and all the hardware was just loose and dangling.
Yeah, I mean, I think what you explained is a rare thing, and it's really whatever your company policy is with closing.
I think that when you said that what y'all do is actually tell the surgeon.
We do.
We close up, and I think that's a good policy.
We do, and we have it. It's in our policy procedure. We alert, and we document in our notes. Due to considerations for anesthesia, we are ceasing the monitoring. Surgeons informed.
And
Do
he
you mind
acknowledges
if
that
I-
now it's on him.
Do you mind if I answer part of that to him?
Yeah.
That's one of the reasons that in US Mon, it has, you've got your closing time, but you have your final trace. So they're closing, and like you said, 10 minutes later, you've got to run another trace because something's happened. You note that, but also in that comment to the billers, make a big bold, because that prints with the biller, a big bold, like this was a special case, look at it, review it. So then they can do some research or talk to Lee or Thomas and say what their decision would be on that. So if you had something weird like that and you didn't know, just make a big old note and note those times, and then.
And guys, I know it doesn't need to be said, but just in case, remember, we take care of patients first, irregardless of billing or money or anything. Make sure your patient is, we do what needs to be done, and don't worry about the rest of it.
And I'll give you another example. In my own case that I did not too long ago, it was a big spinal case. It was really quick. I don't want to get into too much of the details because we're getting off topic here, but it's fine. But the case was going fine till the anesthesiologist gave muscle relaxant and wiped us out for the entire case. I lost my lower motors for the entire case. I knew what it was, and I think I showed you guys this on a case study not too long ago. I finally figured out what it was, and I monitored throughout closure because I knew that when the patient started to wake up, I would get my motors back. So, and I said to the surgeon, I'm going to monitor through closure for this because we lost our motors. And I have a feeling that it's anesthetic related, so I wanted to make sure before the patient woke up that we were going to have something. And what happened was, the patient started waking up, and guess what? I got motors. So there's times to do it and time not to do it, but it all depends on your company policy.
When do you feel comfortable asking them to reverse it?
When do I feel comfortable reversing the paralytic? I feel comfortable reversing the paralytic if I know I need to run a motor and I only have one twitch. Because you have to.
When they just bolus muscle relaxant.
Well, the anesthesiologist was lying to me. He told me he didn't do anything. He was sandbagging me the entire time. But he also has a conflict of interest because he does telemonitoring for another group. It's a whole dynamic. Yeah. It was it's a whole thing. But long story short, if you can't reverse muscle relaxant without, you have to have at least one twitch. There has to be some type of acetylcholine going through before you can reverse it. So if they don't have any twitches, you can't even ask for a reversal. You can ask for it, but they're not going to give it. But once they have one twitch and you have to, you're going to stimulate screws, you're going to stimulate whatever, motors, whatever, would you mind giving a reversal? Look, you can't dictate to an anesthesiologist what to do. You can't say, you need to give a reversal. You can say, can you please give a reversal? And they can either do it or not do it, right? Based on, what they want to do. But, you can't dictate. You start dictating anesthesia and you will not make friends with anesthesia. So, all right, let's reel it back in. So microvascular decompression for trigeminal neuralgia, what structures are at risk, guys? Trigeminal nerve? Which artery? Middle, yeah, I guess. But what else? More importantly, there's a big structure at risk here. What is it? I can't hear you. It's the brainstem. Yes, the brainstem is at risk. So what modalities would we typically use for a trigeminal neuralgia? Bears, and what else? Okay. And what? EMG of what? Trigeminal. What else? Let's look back at so they're going in here, and you remember everything is in this picture, it's spread out, but everything is really close together. So maybe 7, right? Because you're worried about brainstem. 8, maybe 7, and maybe even some of the lower cranial nerves. 9, 10, and 11 could be at risk, depending on their approach. And remember, everything is much closer in real life than it is on these pictures. Okay. So the next type of microvascular decompression is the one, so there's one for trigeminal neuralgia, and then there's a completely different one for hemifacial spasm, which is a cranial nerve 7 issue, not cranial nerve 5. So hemifacial spasm is an involuntary twitching of one side of the face, and it usually starts around the eye and slowly progresses to involve the lower face. Some patients, it starts around the musculature of the mouth, progresses up the face towards the eye. The muscles in the forehead and neck are usually last to be affected in a hemifacial spasm. So we're looking at cranial nerve 7 here. So basically, again, just like the trigeminal neuralgia, it's an artery or a vein impinging the 7th nerve. So the way you can monitor this is you can actually record the abnormal muscle response to identify the blood vessel that's involved causing the spasm. This is one of the only cases that you can immediately know the patient's cured based on neuromonitoring. And the way that's done is called the lateral spread response. I'm going to show you guys how to do that. Have any of you ever done a lateral spread response for hemifacial spasms? So basically, what you do is you stimulate a branch of the 7th nerve in the face yourself, and you record from muscles. And what happens when you have a hemifacial spasm is when you stimulate, for example, let's say you stimulate this branch here to the oculi. What ends up happening is you get a response from the oculi, and then you get a response also from like the mentalis muscle, lateral spread. What happens intraoperatively is they find the vessel that's violating the nerve, and they take the vessel off. When you stimulate this branch, you only get the oculi. This response goes away. That immediately, the surgeon knows that patient's cured based on this one technique. So basically, the technique itself is you stimulate the temporal branch and you record from the frontalis muscle, or you stimulate the zygomatic branch and you record from the oculi. And that's your M response. That's your your muscle response that you want. The abnormal response, then you pick up from either the oris or the mentalis. So you have to go away from a different branch. And the idea is that you're activating these other muscles. So basically, the way you find these branches is you draw an imaginary line between the ear canal and the lateral corner of the eye. So you kind of draw this line from the ear to the eye, and you kind of put your stimulus electrodes here. And let's needle stims right in the bone here.
So kind of like you're doing about overstimulus.
Yeah. Well, I mean, all stimulus you do is
Well,
pretty much
that's
bipolar.
what I'm saying. Like you have 2 needles right there for stimulus, right?
Yeah. So instead of using sticker pads on the face, just put needles there. And basically, the cathode or the negative electrode is placed closest to the ear. Okay. And then, if you're doing the marginal mandibular nerve, and you're stimulating the recordings of the abnormal muscle response, should be made from the muscles around the eyes. So you can reverse it. You can stimulate, and you can set up for both. So basically, you can set up here, stimulate, get the oculi muscle, and get then the abnormal muscle response from the mentalis or the oris, or you can stimulate and get the muscle response from the mentalis or the oris, but then you're looking at the abnormal response from the oculi or the frontalis. So for the filters for these, you should have a bandwidth of 10 hertz to 3,000 hertz. Your time base should be about 5 milliseconds per division, and you start your intensity low, and you raise it until you get an adequate abnormal muscle response. So if you're stimulating too low and you're only getting just the oculi, for example, you want to raise it up until you get that abnormal response from the chin or the mouth. Once the vessel is identified, the lateral spread should go away. If it doesn't, then the surgeon hasn't found the right vessel. And he will continue to do the surgery until he finds the vessel and moves it off. And like I said, it gives an automatic cure. The patients wake up completely cured when this is done. So, kind of show you, this is the lateral spread here. So, kind of show you this frontalis muscle, oculi, oris, mentalis. All right? And check this out. So here is your muscle response, your motor response. Here is your motor response from the oculi and the oris. So we're stimulating and we're getting the frontalis and the oculi. And we're getting these nice motor responses. And obviously in a waterfall, it's very tight the way we're looking at it. Here's the response from the oris and the the mentalis muscle. And then what happens? They find the vessel, and look what happens. It goes away. Right? But this is still there. So they haven't damaged the nerve. They've just gotten rid of that lateral spread. So just kind of recap that. Here's the motor responses, which is nice, entire case. Now this is like quarterly or something happened here, and you see it in every channel. But basically, motor response, abnormal response goes away. Abnormal response goes away. So it's actually a very cool case to do. And like I said, you actually know the patient's cured right there. Right here, this patient is cured. Again, in a case like this, you also do bears, SSEPs, and cranial nerve 7 EMG. You also do a free run EMG. And you can add this if the surgeon wants it. And it's a great modality to use for this. On that, before we get into cranial nerve 9, we're going to take a break and,